Hey guys, good evening. Am I audible, visible? Hello everyone. Just give me a second. Yeah, just give me a second. Hey guys, sorry. Okay. Uh, Hi, Ghost Tab. Okay, Ghost Tab. Good evening. Hello guys, everyone. Good evening. Sorry, I was on a call. Fine. So let's start today. We are going to have one shot of immunology as well as genetics. Primarily, we'll be starting with immunology. Then obviously we'll be moving to genetics as well because the goal is to learn both. I was not able to take classes today, so I'm just going to combine both of them today, right? So let's start. So first to start with, quite a few students asked in the WhatsApp group also, what do I write? Which type of hypersensitivity when I have some particular reaction as a history, right? So please remember whenever it's an allergy type, it is type 1. Anything related to allergy type 1, please remember except contact dermatitis. When I have anything is in contact dermatitis, I had a nickel bracelet, I had an ornament made of copper which is there on my finger, on my ring, where there's a reaction. It is not type 1, it is type 4, right? Except contact dermatitis, because contact dermatitis is the only place where it might confuse you saying that, this also looks like an allergy. Allergic reaction to my metal, it goes in the type 4 hypersensitivity. Please do remember that this is not type 2, this is type 4 delayed hypersensitive reaction, right? Okay, whenever you have antibody formation in any disease, whether there's an antibody formation against an antigen, there's an antigen antibody reaction which is there in the circulation, which is there in your above your cells on a surface, it's predominantly type 2. Okay, type 2 hypersensitivity reaction. Whenever it's in circulating immune complex, primary thing is your SLE. Circulating immune complex I have in the circulation, it's a circulating immune complex which goes under type 3 hypersensitive reaction, right? Sometimes even a planted immune complex like your uh, acute streptococcal glomerulonephritis will also go into that by default, right? Most of the time, most of the places where students get confused is contact dermatitis. Please be careful, it's type 4 and not type 1, right? That's something which you want to start with even before going into immunology reaction, right? So we also have a little bit about you read about the concepts of immunology in your microbiology as well, so I'm not going to take much of time. We'll go short and sweet, what is required to write in an exam point of view. That's what we are going to discuss. For an exam, presentation is sort of different compared to what we read for the concepts. If I know what is the reaction, then I have to have few important headings. What's the reaction? Maybe the other name, the mechanism of the reaction, and if required, if the question asks, little bit about the other examples as well, right? So let's go. So the first one is type 1. Type 1 hypersensitivity reaction is an allergic mediated, like Gosap said, it's a IgE dependent reaction, right? It's an allergic mediated reaction. The key important features, it's an immediate hypersensitivity. Yes, there is a genetic link, not always, but yes, there's a significant genetic link. If your father is allergic to something, there's a possibility that you might also be allergic to something, but in not all the places I'll be able to find the link, right? Some of them are a little bit low lying evidence, not a high level evidence, so that I won't say that it's inherited, but there's definitely a genetic link, right? It's mediated by your IgE secreting plasma cells and also the inflammatory cells is eosinophils. Eosinophils is the response and Ig is the one which is going to spearhead the entire process of type 1 hypersensitivity, right? Type 1 hypersensitivity, immediate, and it always has a phase, right? If you look at any outline of type 1 hypersensitivity, two things are required. We would expect this in every exam paper which is there. First is the sensitization phase. This is the first exposure. Sensitization phase is nothing but a first exposure to the allergen. And the most important thing is, in this phase, there's no symptom, there's no reaction, there's no clinical symptom at all. Very, very, very important. When you have a re-exposure, please write in the brackets with the same allergen. See, if it's a different allergen, let's say today I got exposed to pollen grain, tomorrow I'm getting exposed to a bed bug, I won't have a reaction because that also is be considered as a sensitization phase for the bed bug, right? So if you have a re-exposure with the same allergen, then this is a second exposure. Second exposure will always have an increased immune response and heightened immune response, right? And because of a heightened immune response, there will be symptoms. Symptoms will be present. This is very, very, very important. The first exposure, sensitization, and the re-exposure. The symptom can be urticaria, like Gosab said, is something allergy in the skin, can be a rhinitis, can be a sneezing, can be a bronchoconstriction, bronchospasm, or if I'm going to have an allergy which is like a milk, it might be esophageal spasm or a diarrhea, whatever it can be, right? It's based on the place where the allergen is getting exposed. My symptom will vary. That's why at the start I've said that symptoms present, symptoms absent, more than enough. Whenever you write the dictum, whenever you write this, how it happens, always exceptions are important, right? There is a possibility sometimes the symptoms, right? The type 1 hypersensitivity, or it happens is symptoms can appear even the first time. We call that an anaphylactic reaction. Okay, anaphylactic reaction is nothing but type 1 hypersensitivity, little bit and severe reaction, and it happens without a sensitization phase. It happens even in the first exposure. Most commonly, the example is they are parenteral. The antigen or the allergen enters in a parenteral route. Not always, mostly it's a parenteral route, like a bee sting. It goes and sticks into the blood circulation directly, or a IV injection, or a test dose of a drug, right? So if something goes into the systemic route directly, it's a heavy dose. That's why sometimes my body can react in the first go itself. We call it an anaphylactic reaction, which might be deadly, which might be severe by default, right? Okay. So now we know a little bit about the overview of type 1 hypersensitivity. What's the exact pathogenesis? We have read this. We will read this in the Nishchay. We'll go to your respiratory system. Asthma will have the same template. It will not change, right? So pathogenesis is very, very simple. When you're writing pathogenesis, please draw in a flow chart, because it's much easier for you as well as the teacher to understand, right? You need not have diagrams, just line diagrams, right? You have an exposure to allergen. Okay. When you have an exposure to allergen, so this exposure, let's say, is the oral mucosa or the respiratory mucosa. You have an epithelium, right? In the epithelium, there's a pollen grain. And this will be taken by my antigen presenting cells. The antigen presenting cells will give it to my T cells. At the same time, will it give it to my B cells as well. The B cells is going to produce an antibody, which will be IgE producing antibody will be produced. The T cells now here will go into a different type of T cell response. T cell has 3 different types: Th1, Th2, as well as Th17, right? Here it becomes Th2 cells and it waits. This Th2 cells is going to secrete me multiple more interleukin. It secretes interleukin 13, it secretes interleukin 4, it secretes interleukin 5. Okay, these are the interleukins which Th2 cells. Again, till now I am in sensitization phase only, right? This interleukin 13 will cause little bit of epithelial damage. I will not have symptoms, but I'll have a little bit of dryness in my throat, right? That is because of the T cell secreting interleukin 13, right? The 4 and 5 is going to help me amplify my IgE and also attract my eosinophils, right? That's what my interleukin 4 and interleukin 5 does, right? So this is my first exposure, and this IgE will go and sit on the Fc receptors on mast cells. Okay, this is what we mean by sensitization. It's sensitizing and making my mast cells are cells with big amount of granules. They are nothing but tissue basophils, right? So I have an Fc receptor here. I have Fc receptor here where my immunoglobulin is stuck. It's staying there. The moment it stays there, here my sensitization gets over, right? So when I have a re-exposure, and the most important, like I said in the start, with the same antigen. When I have re-exposure with the same antigen, the antigen goes and binds to the antibody, which is already on the surface of mast cells, right? So you'll have an antigen binds to the antibody, which is here, in this case, IgE on mast cells. If you want to draw a diagram, you draw a diagram, you put the same mast cells and put antigen on top of the antibody. This antigen-antibody binding will automatically degranulate mast cells. So once they degranulate mast cells, there are 2 outcomes for me here, right? One, I can have a very, very, very immediate, because mast cells have lots of granules, right? Can anyone tell me what is there in the granule? All the granule will have your classical preformed content. You'll have histamine, right? So you have vasoactive amines. So already we have preformed inflammatory mediators that will be released. So once they are released, I'll have all of them coming outside. So these are vasoactive amines. So all the vasoactive amines will come outside. That's what will be the first step, right? Please remember the vasoactive amine release is going to cause a hypersensitive reaction, which I will call it as an initial phase. See, actually, the type 1 hypersensitivity cell is immediate. In that, I have an initial phase and then I have a late phase reaction. This vasoactive amines primarily, and also a little bit of lipid mediators. When I say lipid mediators, which includes all your arachidonic acid mediated derivatives, right? This causes the immediate phase reaction or the initial phase reaction. So the immediate phase reaction will happen within minutes of exposure, right? It happens within like minutes of exposure, of re-exposure obviously, and it might last for a couple of hours, right? It lasts for maybe 30-40 minutes maximum. Fine. Then what happens? These mediators, all the interleukins what we have, can actually act as an chemotactic factors as well, right? It will bring in more and more and more new things, right? So all these amines and lipid mediators can act as an chemotactic factors, can bring in more WBCs, right? Can bring in more interleukins and can cause more damage. It will happen. That's how everywhere it's going to happen, right? So these cytokines and the more WBCs, whatever is that, causes the second response we call it late phase response. Okay, so the late phase response generally lasts for from 2 hours to 24 hours. When you have an allergy, you will sneeze immediately for some time, 10-20 minutes, 10-20 sneezes, you'll keep quiet. It'll settle. You'll think that it's fine. Takes up, right? So then automatically after some time what will happen? The cytokines will bring in more WBCs, that's primarily eosinophils, which will release more reactive substances, which will release more of the same about said products. And what will happen? You will end up in having a final phase response, right? So this is the late phase response. This takes this much amount of time after the exposure again, right? So this is the simplest example of or pathogens of type 1 hypersensitivity. We know a little bit of introduction, what is required for me, initially sensitization phase, re-exposure, then we do the pathogenesis. If the question says a history of asthma, what I want you to do is write the symptoms like an asthma. So here, don't just write symptoms in if it's a clinical case scenario, right? Then here you write, let's say there's a patient with asthma. So this will cause increased vascular permeability, will cause bronchoconstriction as per it. If let's say the history is like an you have few more histories here, right? Food allergies. I'll have a different symptomatology. The symptoms or the outcome you have to change based on the clinical scenario given to you, but the standard template pathogenesis is not going to change at all, right? Got it? That's the pathogenesis of simplest way of type 1 hypersensitive reaction. Same for any type 1 hypersensitive reaction, right? Let's go with a few examples with droppers. Always end with examples. Anaphylaxis may be caused by drugs, food. Food is a little bit rare, but yes, it can still can have it. Drugs, bee stings are a little bit more common. Food also might cause sometimes anaphylaxis. Anaphylaxis, the biggest thing is it's a systemic response. When I take asthma, I'll have the interleukins acting here. Yes, systemic. Throughout the body, I am going to have the interleukins acting, causing vasodilatation, increasing permeability. So it may loss of blood pressure and can cause airway obstruction due to edema. It's systemic and it's severe, and the most important thing, they do not have a sensitization phase. Very, very important. So even in a test dose, I should be very, very careful so that I don't miss the patient, I don't lose the patient, right? Then I have bronchial asthma, allergic rhinitis, sign hay fever is something which is very commonly used in the US. We don't use the term hay fever, we just call it an allergic rhinitis sinusitis related due to dust or allergen, right? And food allergies, you must have seen, some of you might have been allergic to food, peanuts, milk allergies, many things can be allergies, which can cause bronchospasm, or it can cause an abdomen cramp, where it's going to trigger the allergy. Based on that, I'll have a not broncho, esophageal spasm causing dysphagia, or an abdomen cramp if it's lower down, right? So these are the examples of type 1 hypersensitivity. We know the template, what to write for type 1 hypersensitivity, right? Let's go to type 2. I'll be covering type 1, type 2, type 3. The reason I'm kind of ignoring type 4 is type 4 is nothing but the same pathogens of chronic inflammation where we read about granuloma formation. Please remember, more and more deep you go into medicine, you'll understand that it is same. Most of them are similar. You should be very cautious in saying that, okay, I read this already there, I'll take it from there and put it here. Please don't reread. It's a waste of time, energy for you guys. Fine. Okay, let's go to type 2 hypersensitivity. Type 2 hypersensitivity is an antigen antibody mediated primarily, right? So the antigen antibody is predominantly made of IgG. Even in future, whenever I read any diseases based on type 2 hypersensitivity, is an IgG predominant. IgM, IgA, E will not happen. IgM, A also can happen, right? So we have three types of type 1 hypersensitivity based on the location of antigen and based on the action of the antibody. Okay, so these are the bases by which we divide them into three different types. If the antigen is located in a cell, in a circulating cell, like a platelet, like an RBC, in a circulating cell. If the antigen is located, let's say, in an surface, I have a different thing, right? If it's located, if the antigen is on a cell which is freely mobile, primarily blood cells. If the antigen is on a surface, I'll have a different reaction. And if you have the antigen or the antibody is against a receptor, I'll have a different action, because receptor are not just proteins, they are functioning proteins. So I can alter the function of the receptor rather than just destroying it. So based on these three, we have three different outcomes. Revision is only with Robbins. The images what is there in the Robbins will convey whatever we need to know about that, right? So this is a simple image in Robbins. Look at the beauty of the image. This is the first type, opsonization and phagocytosis, which is against a cellular antigen, right? So when I have a cell, okay, which this is cell, X cell, be an RBC, a nucleated one, maybe some WBC, right? So I have an antibody to it. So this is my autoantibody. The autoantibody binds on the cell. The macrophage will have FC receptors. Every cell will have an FC receptor where the antibody binds, and I don't eat only the antibody. The macrophage eats even the cell, right? You can engulf the cell and cause phagocytosis. That's my outcome. Or I can have a complement activation where C3b sits on top of the same cell. It's an opsonin. My macrophage will go and bind to it because they do have C3b receptor also, and hence in phagocytosis. Here it's going to be eaten. A cell can be eaten. I cannot eat my skin. Macrophage cannot eat the skin, but macrophage can eat an RBC. Macrophage can eat a platelet, right? So if you look at the examples, autoimmune hemolytic anemia, again cell. Autoimmune thrombocytopenia or immune thrombocytopenic purpura, again a cell. So I have opsonization and phagocytosis. I can phagocytose a cell. If the surface, I cannot phagocytose, so my body reacts in a different way, right? That's why we said we divide them into based on the location of the cell and also the presence of what is a receptor or is just a protein, right? Perfect. Now let's go second guy. Second guy is its complement and FC receptor mediated inflammation. The best example why I'm having a different reaction here is, here it's not a cell, it's a surface. So like I said, I have a skin. My macrophage cannot come and engulf my skin. It's a bit big for a macrophage, right? If it's a free floating cell, I can eat it. So what happens is, whenever I have a complement activity, whenever I have a surface and this is the antigen, right? The red wala is the antigen and the antibody binds to it, autoantibody, or the complement binds to it, whatever it is, right? It cannot eat. Macrophage will come, WBC will come, will bind to it with the same FC receptor, but it cannot eat it. It cannot engulf. So what it will do is, it will actually cleave the complements. It will kind of get frustrated, release the granules, have more and more and more inflammation, right? So this will have more reactive oxygen species, will give more inflammation, and it will cause tissue damage. Here phagocytosis does not happen for the simple reason I cannot eat a surface. Macrophage cannot eat a blood vessel. Can eat a blood cell, not a blood vessel, right? So whenever I have an example where I have antibodies against a surface, right? Let's say vasculitis by ANCA. ANCA is anti-neutrophilic cytoplasmic antibody. Not able to eat, degranulate, destroy. That's all, right? Goodpasture syndrome. Here are antibodies against collagen 4. When I say collagen 4, again the basement membrane. I cannot eat, I cause an inflammation, right? Here, rheumatic fever. I have antibodies mimicking against, you must have read in your microbiology as well, right? Anushama must have told you, right? Against your myocardium, against your epicardium, against your knee joint, right? So again, it's a surface. I'll not be able to eat. I cause inflammation and I cause destruction, right? So this is an example for the second subtype where I'm going to have complement and FC receptor mediated inflammation. Got it? Perfect. Now let's go to the third one. The third one is even more better. First was cell, ate, destroyed, burped. Second, couldn't destroy, hammered, destroyed. Third, why should I destroy when I can just make them lose the function? I'm having a receptor, it's an antibody, it goes and binds on the receptor, maybe it will alter the function of the receptor, that's all, right? So here there are two examples. One is the antibody which binds on the TSH receptor is going to simulate the receptor without hormone, which means this increases the thyroid hormone T3 T4 ka production, right? So you'll have more T3, more T4 ka production, right? This will cause hyperthyroidism or Graves' disease. Okay, like I said, the antibody can mimic the substrate, or the antibody can bind to the substrate and antagonize it. You must read in pharmacology lots about agonism and antagonist, right? So here, this is mimicking, causing more production. And there's one more example where the same antibody can bind to an acetylcholine receptor. Can anyone tell me what will be the disease? Goes and binds to acetylcholine receptors, does not let the normal acetylcholine go and sit because it occupies the space. Not activating, just sitting, occupying the space, not letting normal acetylcholine bind to it, right? So here, which will result in reduced function, and that results in which disease? You already know it. Perfect. Myasthenia gravis. Okay. So this is the third way. If you look at the heading gives me everything. Hi, Jessica. Antibody mediated cellular dysfunction. There's an abnormal function here. There's no abnormal destruction. When I can make them keep quiet without killing them, do that. That's what the third step is. Either I activate the receptor or I inactivate the receptor. So I'm causing a cellular dysfunction, not a destruction. First to me is a pure destruction. I have destruction of the cell by eating or by inflammation. Third me, I have cellular dysfunction only, right? So if you look at this, myasthenia gravis, cellular dysfunction. Graves' disease, cellular dysfunction. Here it inhibits, here it stimulates. So dysfunction can be either more or less. Both are dysfunction only, right? You don't perform well in exam, abnormal. If you get 100 marks in a medical career exam, again abnormal. Both are abnormal for us, right? So we know about both the examples, right? So we know about all the required things for type 2 hypersensitivity reaction, right? Just to quickly go through few information points. It's antigen antibody mediated. Mostly it's IgG, then you have IgM or IgA also. There are three different types based on the antibody against the cell which is, and based on how I'm going to alter the function or how I'm going to destroy the organ, right? So it's either I eat by phagocytosis for a cell which is in the blood, I'm going to destroy if it's in the surface, or I'm going to alter the receptor if it's a receptor. Either I can alter means more production or less production, right? Perfect. That goes my type 2 hypersensitivity reaction. Type 3, there's more likely chance for you to get an exam for the only reason type 3 hypersensitivity is a prototype for SLE. SLE is very simple to create a scenario based question, especially for an undergraduate, right? Let's say most of the time SLE's reaction will be a middle-aged person. Please look into these things very carefully. Women, 25, 30-ish women with bilateral rashes on the cheeks. Classical. If rashes on the cheeks, classical presentation of SLE. SLE can present in multiple ways, but this is something which is very, very common. The malar rash, discoid rash is very common. SLE can cause a renal failure. SLE can cause a cardiac problem. SLE can cause a pleuritis. SLE can cause a cerebral problem. SLE can cause anemia. But the standard one, which I expect for undergraduate, is the malar rash and the discoid rash. Rashes in the face, bilateral in the malar area or in the area of the zygomatic arch. Along with that, you have a history of a middle-aged person who is a female. Always think about SLE. Unless proven otherwise, think about SLE. If there's a lab finding might be, if it's a good examiner, might give you more clue that, okay, ANA levels are elevated, anti-nuclear antibody, anti-double stranded antibody is elevated. Very, very classical for me to know that it is SLE. Okay. This diagnostic of SLE, definitely I can say it's a patient with SLE. Possibility of type 3 to come in a long answer, please do remember that, right? So what is type 3? Type 3 is immune complex mediated. Most of the time it's a circulating immune complex. That's the best example of SLE. There are possibilities. Sometimes it can be a planted immune complex. It's not there in the circulation, but it's on some place. It's an immune complex going and planting in some place, right? This is the best example for PSGN. Post streptococcal glomerulonephritis. Okay, PSGN is post streptococcal glomerulonephritis, classical for an planted antigen example for type 3 hypersensitivity reaction, right? There might be confusion whether it's type 3 or type 2. Robin says type 3, we'll stick to type 3, fine. So the best way to understand pathogenesis, it's a model which you have developed using your older days use of horse serum. We were using horse's antibody to give passive immunity to human beings. The same thing we are doing here also, right? So what you do is, it's a template model, but this is how we say it also happens in your body due to SLE also, right? Template for how you'll have a type 3 hypersensitive reaction with an example of an horse anti-sera being given. We create an horse's anti-sera, which is anti-sera is nothing but the antibody, and we inject it to a human being, right? The moment you give a horse anti-sera or horse antibody into human circulation, by default, the horse immunoglobulin antibody is nothing but the immunoglobulin, right? The red color ones are the horse's immunoglobulin. This is considered foreign. Obviously, it's foreign to human beings, right? When it's foreign to human and it enters my circulation, my body will mount a response to that, right? So because of that, there'll be an antibody formation against the horse's antibody, right? There'll be an antibody formation. Once the antibody is formed, what will happen? I'll have the horse sera antibody here. On top of that, I'll have my human antibody. We'll draw the blue color for human antibody, right? So this is my immune complex. Blue is my human immunoglobulin, which is against my horse's immunoglobulin, right? So this is what I call it an immune complex. Our goal was to treat people, but unfortunately it's reacting back. It's pretty common when we use your snake bite antivenom. Older antivenoms are created from animals, right? So that's pretty common. But these days we have recombinant DNA technology, so this is not at all seen, right? But this is my immune complex. This immune complex will always be in circulation because the antibody what I injected is always there in the circulation. So my antibody, human antibody goes and binds and happens, right? So what will happen if the immune complex, second step is deposition. Without deposition, I don't have much of a trouble. First question, why it will deposit? So here I have immune complex here, right? I'll just, for ease of convenience, I'll convert that horse's antibody into a red color. I have an immune complex here. So now it should deposit. It should deposit on the vessel wall. If it doesn't deposit on the vessel wall, I have no problem. I won't have any pathogens at all. First, why it will deposit? It deposits wherever there's a filtration force. Obviously, if I have a filtration force is always an outward force, right? It's an outward pull. So if I say it's happening in my glomerulus, the same antigen antibody complex goes to my glomerulus. Glomerulus will filter. That's the purpose of glomerulus. Pleural fluid is filtered. CSF is filtered. Joint space is filtered. Wherever I have a filtration force, this force here, this filtration force is an outward force. Because that's how I filter the glomerular filtration, right? Whatever happens for us to form the urine. That will push the antigen antibody complex to the wall, or it will deposit. That's the first thing. Second, wherever we have a bent vessel. When I say bent vessel, it's an hairpin shaped vessel. If I have a hairpin shaped vessel, it's a simple logic. Now, this is how the vessel is. The blood flow is very fast here, but it becomes sluggish here. Again, it's fast here. So this place will get deposited. Simple like a normal hairpin bend, which you must have driven. Like that, obviously in a hairpin bend, it'll slow. When it slows, these are heavy, na? It will get deposited. These are two reasons why it gets deposited. But the moment it gets deposited, I'm having an antigen and an antibody on the surface of endothelium. Enough, na? It will trigger complement. Obviously, it will bring WBCs. It will bring everything, right? So once I have a deposition, rest everything we already know. Actually, once I have a deposition, na, rest everything is like your type 2 hypersensitive reaction, right? It's the immune complex on the surface. So this will activate complement. complement activation will happen. The complement activation, see, it's a routine, you know that. I'll have C3, I'll have C5. C3 might cause inflammation, C5 will cause chemotaxis. These guys will bring in more WBCs, right? When there's more WBC, I'll have more reactive oxygen species, not more WBCs, and ultimately I'll have inflammation. Inflammation where? Inflammation of the vessel wall. In other words, I'll have vasculitis. That's all. You're going to end up in having vasculitis. SLE, PSGN, or any example for type 3 hypersensitivity reaction is nothing but a vasculitis. That's it. Okay, it's a simple case of an vasculitis. Because the trigger of the vasculitis is circulating immune complex or a planted immune complex. Fine, that's how it is. Examples: SLE is a prototype where here I have an antibody against my nuclear antigen, where I have the immune complex against my nuclear antigen. PSGN, post streptococcal glomerulonephritis, where the streptococcal antigen gets deposited, gets planted, right? So here the streptococcal antigen will be planted with the immune complex on my GBM is glomerular basement membrane, or just write glomerulus, that's more than enough, right? Polyarteritis nodosa, it's also vasculitis, where hepatitis B surface antigen will be deposited in the vessel wall. In patients with hepatitis, the surface antigen will be there in circulation. My body will obviously mount an antibody. That happens, right? Reactive arthritis, here bacterial antigen will be there. Okay, the bacterial antigen will get deposited, right? See, if you carefully note, everywhere it's either the arthritis or my vessel or my kidney, wherever there's infiltration force or an hairpin shaped vessel, right? Arthus reaction and your serum sickness, right? Both of them are experimental one. Serum sickness is where we started to find out the horse anti-sera, but we don't use it anymore. Arthus reaction is an experimental one, which is nothing but a localized serum sickness. It's localized, right? It's cutaneous vasculitis. I inject the same horse sera into my skin, I'll have reaction here, right? It's cutaneous vasculitis. It's a localized serum sickness. Okay. Last two we don't see anymore, but the first four are pretty common and we see them on a day-to-day basis. Fine. Done. So we know about type 3 hypersensitivity reaction as well. Like I said, type 4, I'm not going into the depths of it because type 4 is simple. Type 4 is same like chronic inflammation. CD4, CD8, again we know. It goes, eats, destroys. Cytotoxic T cells, right? Perfect. So we know about 1, 2, and 3. Now let's go to grafting. See, grafting, possible to ask in a 5 mark. I don't think they will ask a long answer on a graft. They shouldn't ask a long answer on graft, but I don't know how your examiner is going to think about it. Fine. So grafting is a short answer question. Or in a Viva, there's a very likely chance it may ask, what are the types of graft? These are something which are basic, you must have already know for 12th standard itself, right? Allograft is the genetically non-identical individual. Your brother, sister, mom, dad is also an allograft, right? BD Charosha is good. Autograft is the same person. Taking a skin from one part of my body and putting it to other is autograft. Isograft is genetically identical individual. So if it's genetically identical individual, there's only one part which is identical twins. The monozygotic twins or the identical twins is the only place where this can happen. Xenograft is a different animal, a different species. We don't have xenograft these days, but we were using one of the best examples is porcine heart valve. We were using pig's heart valve for a transplant to a human being. We don't use these days. We have metallic valve, which is much more durable, right? So these are the 4 different types of graft. In graft, actually I can have 2 problems in graft. Any problem in graft can be categorized into 2 different things. One, graft can have a rejection, or the graft can reject the human being. That's my GVHD. Both are exactly ulta. What is graft rejection is, let's say I got a kidney. My body is saying, the kidney is foreign, I will destroy it. That is graft rejection. Simple to understand. Fine. So here, the host immune system will reject the graft, telling it is foreign. Straightforward to understand, right? GVHD is the ulta. GVHD is full form is graft versus host disease. So here what happens is, the graft what we got, if it's immunologically competent, that rejects the host, right? Here, the graft, most likely they should be very much good in immune cells. They should be immunocompetent, like bone marrow, like small intestine, Peyer's patches, right? That graft is going to reject or is going to destroy the host. And the most important thing here is host should be immunocompromised. Because if the host is not immunocompromised, doesn't matter. Graft is this much, host is this big. I can easily destroy that. But the host does not have immunity and the graft has good amount of immune cells. Graft will say, I am the boss, I'm going to kill you. That is GVHD. GVHD is much more deadly because graft rejection maximum will reject the kidney, go back to kidney failure. But GVHD, we can even lose the patient's life, right? And this happens predominantly in your bone marrow transplantation or hematopoietic stem cell transplantation, or happens in even in small intestine transplantation, which is pretty rare to do small intestine, but if it does, the Peyer's patch is there, na? That is the immunological competent person, fine? Okay, done. So now we'll go to graft rejection part. There are three types of graft rejection: hyperacute, acute, as well as chronic. Done. Lakshmi, I did reply to you. Yes, it's a good book. Hyperacute happens, all these are based on timelines. Hyperacute happens immediately after graft in the operation data. Acute happens few months. Chronic happens after years. Because of good amount of knowledge of acute graft rejection and our capability to treat it, chronic has become more common than acute, right? Hyperacute happens between minutes to hours. Minutes to hours. Because of preformed donor antibodies, very important. So what do I mean by that? In people who are at risk, like a multiparas woman, okay, or a person with repeated blood transfusion, okay, why these are required? These are high risk people. So if it's a multiparas woman given birth to like 4-5 kids and one of the kid is giving the kidney, there's a possibility the mother's body can already have an antibody to the kid because the kid stayed 10 months inside the uterus. Antigen must have gone through the placenta, na? Yes. Must have created the antibody and kept silent. First exposure. But when the re-exposure happens, it will kill, right? So in these two conditions, what happens? There will be antibodies against the donor already made, right? Already in the hostess serum. So I'm already having antibody against the donor. So the moment I put the organ inside, kidney or liver or whatever organ it is, it's a secondary immune response. I'm going to reject it immediately in front of the surgeon's eye, right? It's a never happen event. So what happens is, let's say there's a kidney here, there's the host blood vessel, and there's my donor blood vessel. They ligate. The moment they ligate, I'll draw blue color to understand the color combination, right? The moment they ligate, this host already has antibodies to the donor, will bind to the endothelium because that's the first antigen I'm going to get exposed to, right? Goes and binds to the endothelium. The moment it binds to endothelium, so here the antibody will bind to endothelium of the graft. Antigen antibody reaction, that's all, which will cause endothelial damage. Whenever endothelial damage happens, in the last class we read about virtuous triad, which will cause thrombus. In other words, this will not even perfuse the graft. It will go and block the graft, that's all. Graft dies in front of your eyes. Thrombus blocking the blood vessels of not just the renal artery alone. Every tiny vessel, wherever it touches, it will have a clot. It's a infarct, right? Infarct of a solid organ. Can anyone tell me what type of necrosis will I see there? Right? Thrombus, this causes an infarct. I'll have an infarct of a solid organ. Here, obviously, I'm going to see in microscopy coagulative necrosis. The entire kidney will have coagulative necrosis in front of your eyes. It will not even perfuse. That's something which should never happen. How do I prevent this? The test called as a donor specific antibody. Every person who is going to donate, we will test the person's antigen along with the patient's serum, host's serum. If there's a cross reaction, I don't give. Simple to cross matching what you do in blood grouping typing. Same way you do donor specific antibodies. If it's positive, not fit to be a donor, negative, go ahead with be a donor, right? That's your acute, hyperacute graft rejection, right? Acute graft rejection happens within days to weeks. The most important thing you should remember is it's lymphocyte mediated. Though it's acute, I don't have neutrophils here. These are all nucleated cells. Only lymphocytes comes into play. I don't have neutrophils at all in graft rejection, right? Except for the necrosis part, right? So what happens here is I have two things here. Here, the kidney, let's assume, which is the graft, is considered foreign. So my body is going to react in two ways. T cells can identify them as foreign, and I can have a T cell mediated destruction. At the same time, I can also have B cell mediated destruction. So B cell mediated destruction will always be in the form of production of antibodies. So the antibody will be in circulation. Nah? So the antibody will primarily damage vessels. Or in other words, we call it vascular in microscopy. Because antibody cannot go into the tissue. It will be in the vessel. It will damage the vessel. By the way, it will cause destruction. But T cell has two ways. It can be vascular and also it can be interstitial. Or we call it tubulo-interstitial. Okay, because it's T cell. It's not just in circulation. It can go outside and also can destroy, right? So if you look at humoral, I have only vascular subtype. Here I have tubulo-interstitial subtype and also vascular subtype. Right? There are two subtypes in T cell mediated or an acute cellular. In B cell mediated acute humoral, I have only one subtype. The most important thing in addition you have to remember is it's T cell. T cell does not act always alone. It will always bring macrophage together, right? So both of them will be T cell plus the activated macrophage, whatever we read, that's how it's going to destroy them. But here it's antibodies or immunoglobulins. The unfortunate thing about immunoglobulin, they also don't act alone. Immunoglobulins might activate complements. They'll have complement protein activation. Once there's a complement activation, we'll have WBCs there, which will cause a destruction. We know how it's going to cause destruction. The goal is how do I differentiate? What do I see in microscopies? In both of them, you'll have lymphocytes. Lymphocytes within the tubules or lymphocytes in the vessel wall. It's not inside the vessel. Inside the vessel is not vasculitis. No, inside the vessel is normal. If it's in the vessel wall, along with necrosis, it's vasculitis, right? These are images from Robbins. Look at this. This is tubular basement membrane. This is tubule cell lymphocytes. Lymphocytes within the vessel wall, within the tubular lumen, I call it a tubulo-interstitial subtype. It's only lymphocytes. So I have to differentiate them, no? It's difficult for me to differentiate if it's purely lymphocyte. How do I differentiate? I go to pathogenesis. In one of the pathogenesis, complements was involved. So what do I do is, I have a marker, IHC marker or an immunofluorescence marker, whatever it is available, you can do it for C4D. It's complement factor D. If you have C4D, if C4D is positive, it is complement is being involved in the pathogenesis, humoral. If C4D is negative, right, C4D will be negative here. There's no complement involved, I know it is vascular. Sorry, I know it is cellular, right? Look at this. This again, this is a vessel. You can see in this vessel, you have lots and lots of lymphocytes there, small round blue cells, right? This is C4D. Again, an image from Robbins. You can see every vessel here is positive. Brown color is positive here, right? If C4D is positive, I know that in this disease, complement is involved. If complement is involved, has to have an antibody. So it is cellular. Sorry, it's humoral, right? So that's how we differentiate them based on cellular or humoral because the treatment is sort of different. For a T cell, I have a different way to treat it. I use tacrolimus, sirolimus. For a B cell, if it's possible, I can try an rituximab to destroy it, fine? Fatima, I don't know which part you are. Erythroblastosis fetalis also can cause, it's type 2 hypersensitivity reaction, fine? Okay, done. That's about acute. So then come to chronic. Chronic, unfortunately, has become the most common. Months to years, and it's inevitable. No one can stop chronic rejection because it's a repeated vascular damage. Let's say today I had a vessel, I had a reaction to the vessel. You cannot say my body to stop reacting against a graft. It will react. Foreign, it will definitely react. With drugs, I might be able to reduce it, right? I had damage, so I had a fibrosis, let's assume. Give it few months. Already there's a damage here. A new damage came here. A new reaction, new fibrosis came. Give it more months and years. Repeated damage, what will happen? It will make my entire vessel wall full of fibers, right? Repeated damage. What this is called? This is called as a graft arteriosclerosis. Sclerosis means thickening. The graft arteries become thicker. Problem is not thicker. When they become thicker, there will be reduced lumen. When there's reduced lumen, there will be reduced blood supply. That will cause infarction and will cause fibrosis. Obviously, when the organ dies, the function reduces. I'm going to say it's a rejection, right? Thing is, this is inevitable. I cannot stop this. It'll happen. Lucky people might happen in 20 years. Unlucky might happen in 5 years, right? There's an image of graft arteriosclerosis. There's a vessel. You can look that. This is the only lumen available in the vessel. Rest everything lumen here is filled with fibrous tissue, right? This is your graft arteriosclerosis. Because of this, this happens. This is a Mason's trichrome stain. Mason's trichrome stain will pick up collagen having anything, right? It's destroyed. It's replaced by fibrosis. It's a dead part because of the infarct, right? Here, yes, I can still see the tubules here, right? A little bit of glomeruli here, but niche, everything is destroyed. This is what happens because of graft arteriosclerosis, and that's what happens in chronic rejection, right? So we know about acute, we know about chronic as well, right? And also we saw about hyperacute, right? So we saw about two different things, right? So we saw a little bit about type 1 hypersensitivity, type 2 hypersensitivity, and also we saw about graft rejection, right? So I want to go a little bit to genetics. If you look at your CBME curriculum with respect to genetics, they want you to know the basics. I don't think they'll be asking questions on that. And they also want you to know about chromosomal disorders. Unfortunate thing is, sometimes they don't listen to CBME curriculum. Your examiners might ask about Marfan syndrome, might ask about Ehlers-Danlos syndrome. Mediated has a recorded lecture which covers in detail about genetics. Even in INICET, I have restricted to CBME curriculum. I hope they will restrict to CBME curriculum as well in your college, right? So in that, we'll talk about Downs and we'll talk about Turner's. These are two chromosomal abnormalities mentioned in your curriculum, fine? Everyone knows about Downs, right? Can anyone tell me what is Down syndrome? Same template. We need first 2 points. What is Down syndrome? Pathogenesis, clinical features, diagnosis. Treatment is not there for Downs. It's a genetic disorder. We don't have any treatment, only supportive care, right? Downs is one of the most common viable aneuploidies, right? It's trisomy 21. Okay. So if we talk about the risk factor of Downs, see, Downs is genetic disease. Please write, it's not inherited disease. Maybe not in an exam, but please understand Downs is not an inherited disease. Downs is a genetic disease, that's all. Right? It's not inherited at all. It's a sporadic disease, which means anyone in this world can have Down syndrome. The risk factor is one important thing, maternal age of consumption. If it's more than 35 years, we call it a high-risk person. Please listen to me carefully. I'm not saying if a woman is above 35 and gives birth to a baby, she will have Down's baby. Not. The risk increases. Above 40, risk increases a little bit more. Above 45, the risk is even bit more. It's risk, not the etiology. Why it is risk is because in women, right, it's a bit different from men. The oogonia is seen in embryonal period. It's produced in the embryonal period. In a man, spermatogenesis or spermatogonia, 35-year-old women's oogonia is 35-year-old, right? So here, at 35 years, the age of oogonia is very, very, very high. Is 35 years or 40 years or 45 years based on the age of the mother, right? So there's a chance of error. That's all. Anyone old makes an error. Old sperm also makes an error. But for a spermatogonia to be 30 plus years, it will take a lots of time. It won't happen like that for oogonia, right? Because oogonia is seen at birth, in embryonal period, it's arrested in the Pachytene stage and it stayed back. That's why there's a problem. Older it becomes, older you have a problem, right? So it's a risk factor, right? So what happens? If you look at the pathogens of Down syndrome, there are three important pathogens. Non-disjunction, 95% of them are non-disjunction. Robertsonian translocation, 4%. Mosaics. Mosaics in Down syndrome is 1%, right? You have to be very careful in that. 95% of Downs is due non-disjunction. We call it meiotic non-disjunction. Okay, you can either write in the form of a diagram or you can write in the form of a text, whichever is comfortable for you. Non-disjunction means during meiosis, the chromosomes are not separating properly. Non-disjunction. That's what it means, right? It just means during meiosis, there's a fault in separation of chromosomes. That's what meiotic non-disjunction means in text. If you want to draw a diagram, we have two meiosis, right? Meiosis 1 and meiosis 2, if you remember your school days. Normally, let's assume that this is chromosome 21. Please assume rest every chromosome is completely normal. Since it's Downs, I'm talking about chromosome 21 alone, right? Divides. First phase, it becomes like this. It's still diploid. The haploid happens next, right? And then it divides again. Ideally, what should happen? One arm should go here. One arm should go here. That gives me two ovum. And both these ovum are haploid. N, right? But an error happens, non-disjunction, not separating, goes like this. And here, there is no 21st chromosome. So what will happen here is, I'll have N haploid plus one extra chromosome. That extra chromosome is 21. This, when it fuses with the sperm, results in a Downs baby. Right? Again, the sperm should be normal. If the last ovum, N minus 1, right? This is N minus 1. If this fuses with the sperm, just for us to understand, it will result in aborted, which will not be alive. This is what happens in Downs. That's one more reason that more the maternal ages, the chance of abortion is also more, because not every genetic disorder will have a live baby. Only alive monosomy is monosomy X. Any problem in any other chromosome, abortion. There are only 3 alive trisomies, 13, 18 and 21. Rest any trisomy will be aborted. Right? So there's a possibility that I'll have an extra 1 chromosome here because it's not disconnecting and going properly. That's non-disjunction. Simple, right? So it's the commonest pathogens of Down syndrome. 95% of them are non-disjunction. What's Robertsonian translocation? Not that common. 4% of Downs will have Robertsonian translocation. Here, few important notes. Mother's age is not a risk here. In other words, it can happen even in 20-year-old mother, 25-year-old mother, 35-year-old mother also, right? Here, the one more important thing is the chromosome number in this patient will be 46 only. It's actually an extra load of 21st chromosome, not extra 21st chromosome. Why it happens like this? Robertsonian translocation, actually the pathogenesis, it happens between two acrocentric chromosomes. That's what Robertsonian translocation means. 13, 14, 15, 21, 22. All these 5 are acrocentric chromosomes. Acrocentric ka matlab very small p arm, long q arm. That's acrocentric, right? Let's say there are 2 acrocentric chromosomes, 14 and 21, right? Translocation between 14 and 21 is the most common cause of Robertsonian translocation Downs for an MCQ, right? This is what will happen. I'll have 2 Q arms and 2 P arms. This is translocation, right? This might be lost, right? So this Q arm, this has both chromosome 14 Q plus chromosome 21 Q. This is the extra load which I was talking. So this patient will have normal 21, which has 2 arms, plus an abnormal 14, which also has one more 21. That's why I have an extra load here, right? So it's extra load. Along with that, you'll have normal 21st chromosome also. So it is symbolically trisomy. Since it's a translocation part, it'll have 46 chromosomes only. Fine. It's just 4%. Just remember that alone, right? Last but not least, mosaic. Mosaics are 1% of Down syndrome type. That's mosaic. If you take the blood test of them, they'll show normal as well as they'll have trisomy. We call them mosaics. Fine. Done. Done. Okay. Now approach diagnosis. How do I diagnose a patient Downs? Undoubtedly, Downs is a clinical diagnosis. You'll have lots and lots and features which you have to remember regarding Downs. For this level, for a second year level, please don't forget a few things. Increase neck thickness. That's one. I think there's a glitch in the YouTube. Give me a second. It'll come back. Just give me a second, guys. YouTube is becoming glitchy these days. Okay, I hope it's back. Yeah, sorry. So there are a few things which you should not forget in Down syndrome, right? Increased nape of neck, the thickness in the neck region. That's one thing, right? Second, you'll have an epicanthic folds. There'll be folds seen in the epicanthus, right? One, intellectual disability. Mental retardation is an old terminology, not to be used as per WHO. Please don't use them. Please use the term intellectual disability. Very important to stay legally correct as well, right? This is the most common cause of intellectual disability, right? Patient will have an increased neck skin thickness, right? There'll be a transverse palmar crease. We call it a simian crease. These are phenotypic change, right? There'll be a thick epicanthal folds, right? You can have epicanthic folds. There are few common morphological symptoms, and one of the most important findings is increased space between first and second toe, the great toe and the second toe. In addition to this, you might also have increased risk of these conditions. There's increased risk for congenital heart disease. There's increased risk for umbilical hernia, right? There's an increased risk for leukemias, and even there's an increased risk for Alzheimer's, right? All these will have increased risk. So I have few phenotypic and few classical findings of risk factors which are seen in Down syndrome. It's primarily a diagnosed based on clinical basis. Obviously, you do a fish or a karyotyping to confirm it's a trisomy, right? Also, once you suspect, obviously you do a investigation of choice, can be anything, could be fish or a karyotyping. Here I don't mind what you're using because both of them can pick up Downs pretty easily, right? The goal is prenatal diagnosis. See, diagnosing Downs after being born is very simple. A junior doctor can also easily diagnose Downs before it is after it's born, right? It's a clinical diagnosis. Once you see, you'll not forget, right? So what do you do for prenatal diagnosis? Because as per Indian law, if a baby is having Down syndrome, there's an option to abort the baby, citing that the baby is not healthy. So I have to have a prenatal diagnosis, right? How it goes is, initially what will happen is, initially there will be something called an anomaly scan. Anomaly scan, you will read in OBG, which sir will be talking about that. In anomaly scan, there will be increased nuchal fold thickness. Same, thick skin, nuchal is neck, right? Increased nuchal thickness or increased translucency in the nuchal area. This I'll have to suspect Downs, not diagnose. I'll have to suspect Downs. Then you have to do blood test for the mother, not for the kid, for the mother. Again, you'll read that in OBG. There are some tests called a triple test, so quadruple test. We do them. Okay. So once you do a triple or quadruple test, again there'll be a suspicion for Downs. The only way to confirm Downs is do a CVS, which is chorionic villus sampling or an amniocentesis. Fine. It's chorionic villi. It's nothing but biopsy of the chorionic villi sampling. This will give me genetic material. I do a karyotyping and then I can confirm Downs. Okay. This is how we have been doing all these years. This is a way to have a prenatal diagnosis. If we don't have a prenatal diagnosis, because this route is a bit tiresome, bit expensive, and CVS will be done around 16-17 weeks. Legal age of abortion is around 20 weeks. Beyond that, we cannot abort. It will go into the court, it will become a legal issue. So I'm giving very less time for the family to decide. So there's a newer test. I want you guys to write this also. Non-invasive prenatal screening or testing. This can be done around 9th week of gestation. Very, very, very important. See, it's not only theoretical. Touch wood, nothing will happen to your known people. If someone is having a suspicion of Downs of an elderly pregnancy, do this because it's much, much more cheaper, much more effective, and gives a very good time, right? 9 weeks test will take 1 or 2 days, max a week. Mostly it will be written in 1 or 2 days answer, right? So in what we do here is, here we'll take 10 ml of mom's blood. When you take 10 ml of mom's blood, in this we'll find something called an circulating fetal DNA. Like someone commented on erythroblastosis fetalis. When RBC can cross the placenta, WBC also can. Circulating fetal DNA. We'll filter the circulating fetal DNA. That's the geneticist's job, right? We'll filter that. Once I get the fetal DNA, we'll run genetic test on that to confirm the diagnosis. So it gives a result in 9th or 10th week with a certainty of 99% sensitive and specific. It's a pretty good test, right? The adaptability is required. If it says, this patient, again, there's a problem or glitch in YouTube, I think it'll become normal soon. If I can say that this patient will most probably have Down syndrome, will left to the parents to abort or to continue, because I can say it's Down's baby, that's all. I cannot say go and abort. That's their cause, that's their wish, that's their rights to choose whether to abort or not, right? This is the best test available, non-invasive, because I'm not touching the baby, I'm taking mother's blood. Prenatal testing or screening, right? You have to know about that, right? That's about the diagnosis of Downs. We know about Downs, pathogenesis, clinical features, and diagnosis. Let's go quickly do Turner's as well. In Turner's to start with is the only alive monosomy known to humankind. Every other monosomy dies in utero, there will be an abortion. 45XO, or just if you can write 45X, that's more than enough. Both are Turner's only. Turner's has the same pathogenesis. We read now the same pathogenesis. There's N-1. If the N-1 is X chromosome, causes Turner's. Something called an anaphase lag. What it means is the extra arm, or not the extra arm, the arm, which has to reach the ovum, will lag behind during anaphase and will be lost. So I lose the chromosomal material, so we call this. Fine. So I lose the chromosomal material and I call it, yes, there's a loss of X chromosome, so it's a Turner syndrome, right? Or it could be structural abnormality. That is pretty interesting. Turner's is not just due to your aneuploidy. It is primarily most of the time due to aneuploidy only, but there are quite a significant structural abnormality also in Turner's. What are structural abnormality? You have something called a ring chromosome. Let's say a normal chromosome ends are being cut. When you have cut ends, you know that every cut end of the DNA is sticky. So it becomes like this. It becomes like a ring because the ends are always sticky. They go and stick to the other end and becomes a ring. The problem with this ring is it's a physically present chromosome but not functional. Because for a chromosome of eukaryote to function, it should be straight. I don't have a circular DNA. We have a linear RX. One X chromosome is ring. It's Turner. The most important thing is these are structural abnormality. So please don't write 45. It is always 46. Every structural abnormality, be it Robertsonian, 46. Ring, 46. Iso, 46. Inversion, 46. It will be 46 only, right? What does isochromosome mean? So normally what will happen when you have a chromosome during anaphase or metaphase, when it divides, we will divide vertically. That's a normal plane of division. The normal plane of division is always vertical, right? So it's vertical, it splits and goes. But as an error, if the plane of division becomes horizontal. What happens? I'll have one zygote or one chromatid with two Q arms. I'll have other with two P arms. We call this iso, same chromosome, right? Turners can be due to isochromosome of Q arm plus P arm. Fine. Okay. 1, 2. Learning is learning, right? Board or iPad doesn't matter. Stick to me. If you don't understand, let me know. I'll answer because I'll be more energetic writing here than on a board. Okay? Fine. Now, come back to this. So I have isochromosome, right? So isochromosome can be both due to isochromosome XQ or XP. But most of the important chromosomes genes are in XP. So when I have 46X, I for isochromosome, XQ, which means this patient has 2XQ, no XP, right? Indirectly saying no XP. So the most important genes are lost. So the most important genes are lost. That means I'm going to have a isochromosome and I'll have Turner syndrome, fine? That's what it is. So I can have Turner's due to this structural abnormality. I can have Turner's due to this structural abnormality. In both structural abnormality, it's going to be 46 and not 45. Please remember, right? So now we know the pathogenesis. We'll go to the symptoms of Turner's. Turner's ka symptom na? Turner's baby, unfortunately, touch wood, should not say that. God forbid, they look like clowns. Most of the, if you have been to circus, you must have seen tiny kids who walk like this. They are most likely Turner's kids. Turner's, the mnemonic is also clowns. C for congenital heart disease. You can also have coarctation of aorta, right? L for low thyroid, and the hairline will become low. Not a long hair, the hairline weak ovaries. Because it's only one X chromosome, no? Ovaries cannot be functional, right? For a female to be functional reproductively, I need 2X chromosome. Here only one X chromosome, not functional. If ovaries are not functional, menstruation will not happen. That might be the primary symptom where they come to the physician. Primary amenorrhea. They will not have menstruation at all, right? Because ovaries are getting atrophied. Next, webbed neck for W. Webbed neck is because there's a lymphedema here. We call it, technical term for that is cystic hygroma. Cystic hygroma is nothing but you'll have lymphedema in the neck. Okay. Then N for nipples being widely placed. It's actually not a nipples problem. It's a chest wall deformity. These patients have something called a shield shape chest. It's a chest wall deformity. So the person's chest is like this, like a shield. So obviously nipple become widely spaced, right? That's a classical phenotypic feature. That's why I said if you've seen kids walk in the circus, they're like this, most likely Turner's kid. And most of the clowns in the circus are short. That's the most common feature of Turner syndrome, short stature, and a very, very, very specific symptom, short fourth metacarpal. If you take an X-ray, the fourth metacarpal alone will be small, right? A short fourth metacarpal is again a very specific finding for Turner's, right? Clowns is a mnemonic for Turner's. Hopefully, if it strikes you in the exam, it'll be great for us, fine? Okay, that's about Turner's. Again, I don't have a treatment for Turner's. Nothing to do. Life expectancy is decent. Might not be able to have a baby because of primary amenorrhea. Fine. Okay, done. So we have seen few important things here. We have seen about type 1, type 2, type 3 hypersensitivity. We saw about graft rejection, and we saw about 2 genetic disease, your Turner's as well as Down syndrome. Fine. Okay, that's for the one shot of immunology and genetics. We'll have neoplasia in the next class, but I have not completed neoplasia in your Nischay batch. So I would say please go to Nischay batch than this. Okay, fine. Thank you for your time, guys. Any doubts? Put in the